Thank you, and thank you for inviting me to join you today. I'm going to try and explain how NICE uses the data collected in registries and national audits and what contribution it can make to the things that NICE does with its guidance and other outputs. The relationship between registries and evidence is quite complex. Registries and similar observational databases collected over a period of time and usually containing large amounts of data on a large number of patients are useful in understanding both the natural history of the disease and also the way in which care is organized. And they are particularly useful, I think, in developing hypotheses for the way things should change. The original guidance that NICE inherited back in 1999 was a program of cancer service guidance. Some of you may be familiar with it as improving outcomes guidance. And the events that started off the cancer service guidance were called hypothesis-forming events, and you can't start developing guidance until you understand what the issues are, and having a large database of patient experience is a very good starting point for understanding the issues. Having posed the questions, if you like, NICE then looks at published evidence from properly designed research to test those hypotheses. Evidence from that research then informs the content of the guidance. The guidance is then implemented, presumably, and the extent to which that guidance has been successfully implemented is determined by audits. And so registries can provide both the means of starting off the process of guidance and monitoring the implementation and then revisiting the hypotheses or creating new ones. So in a way, it's both chicken and egg. NICE, as those of you who've been involved in developing guidance for us will know, NICE assesses the quality of evidence using a tool known as GRADE. This is not necessarily, and not just, a tool to assess the quality of the research, although it does do that to a degree. It looks at both the research itself, the outcomes, and the context within which the research is done. So it's about the quality of the evidence and therefore its usefulness for informing guidance. Now, although we don't have a hierarchy of evidence within NICE, for the purposes of this evaluation, the GRADE tool starts randomized controlled trials at good and observational studies as low, and there are also measures of very low and moderate. But the adjustments made, for example, the quality of the investigation itself, the completeness and recording of data, the reliability of the findings, for example, if they vary from those in other studies, and a number of other issues such as consistency, can lead RCTs to being banded very low, and some observational studies to be treated as high-quality evidence. So it's not necessarily a hierarchy between RCTs and the rest. And large observational databases are extremely useful, especially when there isn't much else to go on. NICE guidance is quotes based on the best available evidence. Not all of our guidance, as many of you will know, is based on good quality evidence, because there just isn't enough of it around. But we use the best that there is. We do not, however, create magic out of uncertainty. Quite often, well, continuously actually, over the last 15 years, whenever ministers have been faced with a problem, they give it to NICE, thinking that we will somehow create something out of nothing. We don't. We look at what evidence there is available and usually have to say something, but we don't pretend that we can create hard fact out of massive uncertainty. But it is our role to reduce the variation in practice, and particularly to focus on clinically unjustified variations in practice. A typical guideline will contain 20 clinical questions which are answered, so that's 20 systematic reviews of the evidence. We do not use reviews carried out by other organisations, and we don't use guidelines developed by other organisations, but of course we do look at the same evidence that they have, so not surprisingly from time to time come out with the same conclusions, although NICE is the only large guideline developing organisation that looks at cost effectiveness as well as clinical effectiveness. So the outline process that we adopt in developing the longer forms of our guidance are three main phases. Firstly, the scope. So this defines what we cover and what we don't. We profess not to write textbooks, given that some of our guidelines have 1,000 pages. I don't know what a textbook is meant to look like, but we do not pretend to cover everything, whereas I think many professional association guidelines, including your own, do actually try to cover everything, a daunting task that we do not attempt to emulate. We particularly focus on areas of uncertainty and also on areas where there is clear evidence of what to do, but some evidence where it's not implemented well. The scoping phase generally takes around 6 months and includes a public consultation on what we will include and what we won't. Then we go into the development phase of the guideline. There's no standard time for this now. We decide what's important to cover, and then we agree how long it's going to take. But a typical guideline will take 70 weeks in the development phase. In this, we review the evidence, we translate that evidence into recommendations using an expert group, and we almost always build health economic models to focus on the key cost effectiveness issues within the guideline, but not everything. We then validate the guideline through a consultation process, typically for 6 to 8 weeks. We often obtain independent peer review, not so much of the content, but of the way in which the evidence has been assessed by the developer and the relevance of the conclusions drawn to the evidence which informs them. And then we have our own internal quality assurance process of both the core analysis and the cost effectiveness, and we have to align it with the 1,200 other pieces of guidance that NICE has now produced, an increasingly difficult task. Validation takes about 7 months, and then we publish. Now, all NICE guidelines are published in NICE's name. The one that was shown earlier is actually headed by the logo of the Royal College of Physicians. The developers, who are 3 Royal Colleges and Velindre Hospital Trust for Cancer, do in fact produce hard copies of the full guideline. We do not. We don't publish the full guideline at all, and the guidance belongs to NICE, and very occasionally NICE overrules the guideline development group. It's happened twice in 2.5 years, so don't panic. Now, when do we use observational studies? Well, they're very, very important in setting the scene. There is a section, and certainly in the full guideline, and to a limited extent in the other material we produce, including press releases and the introduction to the NICE version of the guideline itself, which describes why we're doing the guideline, how things are now, and how we want things to change. And in particular, we're interested in aspects of care where there is variation in practice. So the observational databases are very useful to formulate clinical questions. And in the absence of comparative studies, often registries and audits are all we have to go on. So we do sometimes base the content of guidance on registry data. It's particularly important in areas where there's a long pedigree of collecting high-quality epidemiological data, for example, in cancer, and the national audit of lung cancer, so-called LUCADA, which has now, I think, been running for 11 years, is becoming one of the most important sources of intelligence for our guidance on lung cancer, as it is in the other countries of the UK, which produce their own guidelines. Then at the other end of the pathway, monitoring implementation of guidance is a difficult task for us. We have a tiny number of people involved in our implementation team, so we are to a very large extent dependent on national audits and professional associations to document what is changing in practice, and registries of the type you are developing here are absolutely crucial to enable us to monitor implementation, and this is particularly important when it comes to reviewing and revising quality standards, as I'll come to in a moment. And we also recognize that actually measuring and counting things helps us to evaluate the effect of guidance on outcomes, recognizing that there's a lot of noise and guidance is just one blast on the horn in quite a noisy environment. So what are clinical guidelines? Well, they're not mandated in the way that technology appraisals are. The current mantra at NICE is they are guidelines, not tramlines. We are concerned that some clinicians, particularly the more junior ones, are no longer able to make clinical decisions. They just turn to the guideline. That's not what guidelines are intended for. They are meant to advise, but the clinical responsibility for every decision rests with the responsible clinician. However, NICE guidance is expected to be taken into account by commissioners when designing a service and commissioning it, and it's also intended to be taken into account by practitioners when making clinical decisions. In most cases, perhaps 80 to 90%, we would expect NICE guidelines to be followed. It is a very useful defense when in court to say that I have followed NICE guidelines, but they are not necessarily the right thing to do for all patients in every setting. And one of the biggest problems in our guidelines program is the total of guidelines approaches 200, and it will eventually level off at around 230 in 4 years' time, is keeping it up to date, which is what I've been addressing in the last year or two. So I think the atrial fibrillation guideline that we published today is about a number 180. We have 62 guidelines in development at any one time. So we're going to hit a figure well over 200. Many of those are updates and they're replacing older products, but we have 32 de novo guidelines yet to be commissioned. So this is going to be a big portfolio, the biggest in the world by some distance. Using our conventional process, it takes between 18 and 30 months to update a guideline, and I would have to treble the capacity of the program to keep all the guidelines up to date using conventional methods. And no one's going to give me the £15 million I need to do that. So instead, we have established a number of standing committees, 2 operating now, 2 more coming into existence in 6 months' time, and 2 more by the end of 2015, to handle a range of small updates at more frequent intervals. So we're now reviewing the content of guidance every 2 years and the scope of guidance every 4 years, and updating soon and quickly when it's appropriate to do so. Now, in the future, we would want to move towards something even more dynamic than that. And in particular, when important new evidence emerges, we don't want to have to wait for the NICE process to grind into action. So we are piloting a process with the NCRI, the National Cancer Research Institute, initially, looking at the clinical trials portfolio and identifying a number which we think will impact on guidance, and then working with the principal investigators before publication so that we can review the guidance before it hits the press and put the update into progress immediately that the contents are peer-reviewed and published or prepared for publication, and would expect to have new guidance in place within 6 months of publication. Over the next 3 to 5 years, we hope that about half of our guidelines will be covered by this process. It's a completely new venture for NICE, which normally does things at 3 to 5 year intervals, but it is how NICE envisaged guidelines would operate back in 1999 when we started. So there's a slide missing here actually, which I did send him, and that's about quality standards. So I want to say a few things about those first. Now, quality standards are based on NICE guidelines. That's a marginal exaggeration. They're actually based on NICE guidelines, or in the absence of NICE guidelines, other guidelines accredited by NICE. Now, when I last spoke to the BSG, the organisation was considering an application for accreditation for its own guidelines. I'm not sure if that's gone through yet. But we do use guidelines from other accredited organisations to inform quality standards, but the vast majority of them, about 96% of statements, are covered by NICE clinical guidelines, which is fine. The purpose of standards, quality standards, is a little unclear. They have all-party political support in the Commons, but for what is not entirely understood. They are currently being used by NHS England as a sort of prioritisation of recommendations to support within clinical guidelines, although I think it goes a little further than that. The issue, of course, is that just as guidelines cease to be current, so will quality standards. The current process is that standards will be reviewed every 5 years, but of course if the guidelines are updated more often and you are able to demonstrate through your registries that a standard is universally adopted, then they cease to be relevant as quality standards. And so I think that a combination of the rapid updating and continuous updating of guidelines, together with the continuous monitoring of practice through registries and audit like yours, will enable us to sharpen up the whole quality standard process and make them more relevant and therefore more likely to be used. So in summary, NICE guidelines follow a consistent and systematic process, which is our greatest defense against the forces of evil. Our portfolio is huge. Updating them and the standards which are based on them is becoming a very significant task. But clinical databases, like your registry, are important tools for us in posing the right questions, in defining current practice, and in monitoring implementation and impact. Thank you.